Good afternoon, everyone. It's with immense pleasure that we welcome you all to this webinar titled Application of Microskills in Social Work Practice, which has been organized by the Department of Psychiatric Social Work, NIMHANS. So we have three eminent speakers, Dr. VP Nirmala, Dr. Damon Queen, and Dr. Kanmani TR, who will be speaking about different settings, how microskills can be applied in those settings. And we have Dr. R. DHANASEKARA Pandian, who is the chairperson for the webinar. So, Dr. R. DHANASEKARA Pandian, he is the professor and head of the Psychiatric Social Work Department in NIMHANS, and he has been actively involved in the clinical and research areas associated with the department. His areas of specialization and interest including obsessive compulsive disorders, social pathology, suicide prevention, community care for addiction disorders, corporate social responsibility, spirituality, counseling services, and working with the NGOs, to name a few. So now I request Dr. R. DHANASEKARA Pandian sir to give overview of today's program.
Namaskar. Good afternoon. I'm extremely happy and proud to welcome all of you for the today's micro skills training from the Department of Psychiatric Social Work, National Institute of Mental Health and Neurosciences, Bangalore. You all know the Department of Psychiatric Social Work at NIMHANS is one among the largest department of psychiatric social work, not only in India, not only in Asia, to our knowledge, in the world, one among the largest departments of psychiatric social work. We have 22 faculty members who are posted in all the areas of neurology, neurosurgery, psychiatry, all the specialized clinics, all the extension services of NIMHANS, and our faculty members of the Department of Psychiatric Social Work. They work on all the areas: treatment, rehabilitation, prevention, promotion, rehabilitation, and also having a support network for the clients and their family members. The department have MPhil in Psychiatric Social Work program. We also have PhD in Psychiatric Social Work program. Every year, we take nearly about 30 students of social work for their higher learning in the area of psychiatric social work. Presently, we have nearly about 50 PhD scholars. Most of them, after their MPhil in psychiatric social work, they also pursue their PhD in psychiatric social work from our department. The department also has nearly about 20 psychiatric social workers who work for the welfare of our clients and their family members in all the clinical services and allied services of NIMHANS. The Department of Psychiatric Social Work, apart from our regular training in MPhil in Psychiatric Social Work and PhD Psychiatric Social Work, we also have many training programs for professional social workers and allied professionals from all over the country and our part of the Asian continent actually. Every year, we get nearly about 600 to 700 block placement fieldwork trainees from all over the country for learning special application of social work practice, particularly in the area of psychiatry, neurology, and neurosurgery. In fact, Dr. BP NIRMALA and Dr. KANMANI, the coordinators of this program, they are also, apart from their additional work, they also take care of the block placement trainees of our department. In fact, they have a very rich experience on coordinating the block placement training. In fact, because of this pandemic, now they have an online kind of block placement training for professional social work trainees from the country actually. The Department of Psychiatric Social Work very recently, after this pandemic situation, we have developed telepsychiatric social work guidelines so that the professionals can provide their services through the telemedicine kind of a way. That was a welcome move. There are many more kind of update So what the Department of Psychiatric Social Work in general, we believe we have to update our knowledge. There are many kind of changes, there are many kind of the challenges occurring, and depends on the need of our client. We have to update our knowledge, and we have to, so that we can provide a meaningful kind of service delivery to our clients. As we all know, what's happening today, apart from the traditional social problems, there are many lifestyle related disorders are emerging in our population. For example, India is the capital for diabetes, hypertension, and other lifestyle disorders. In fact, diabetes, hypertension, cardiovascular disorders, stroke disorders, chronic kidney disease, and many other allied diseases are one among the major kind of a difficulty for our population. In fact, anxiety and stress related disorders are emerging as a major barrier for development. Addiction related disorders, lifestyle related disorders, suicide, and many other allied kind of a difficulty, one among the major difficulties of our population. So, apart from providing the routine clinical services, the professional social workers and allied professionals, we have to update our knowledge on various micro skills related to our professional practice, so that we can provide a higher quality of services to our people. The concept of life skills. In fact, the WHO, World Health Organization, strongly advocates life skills as a kind of a major kind of service activity for all the people, and it has a high relevance for our people. So there are many practices, many kind of the new methods are emerging that will be very very useful for our clinical practice, and that's the reason we are planning to discuss in detail about the micro skills. As a part of our training, all our MPhil trainees, they also, when they enter the department, we start them with the micro skills actually. And now for that also extended to all the block placement trainees, now we thought there is a need to empower on micro skills of all the professionals who are need of such kind of services. That's the reason, with this background, we have initiated this training program today. We all know that the micro skills training, the relevance of micro skills training, the importance of micro skills training, and how the practical application of micro skills training that my colleagues, Dr. BP Nirmala, Dr. Kanmani, and Dr. Yaman, all the three people they will discuss today. So I'm extremely proud. I'm very happy that this is one among the kind of a great opportunity for all of us to meet all of you, and we will also like to listen to all of you by virtue of your participation, so that we all can update our knowledge and provide a higher quality of services to our clients and their family members. With this background, I sincerely thank every one of you for choosing this training program, and I'm very happy to invite all of you for this program. I request my colleagues to kindly document all your queries and in the program, so that we can also, this will be a continuous kind of a program. Some of your observations will be taken care, and so that we can also incorporate in the future training. With these few words, I welcome all of you. There are many senior people are also logging. I am extremely thankful to them, very especially my professor Dr. Tirumurthy, our professor and our former head of the Department of Psychiatric Social Work, who is an authority in the area of providing psychosocial counseling in variety of disorders, including geriatric psychiatric services. So Professor Tirumurthy also available, and many of my other colleagues, Dr. Janardana and many other faculty members from my department, and all my allied Department of Psychiatry, Clinical Psychology, Nursing, Mental Health Education, and many other department of NIFANS. Also, they have logged in today. So I am very, very confident this will be a kind of a great opportunity for all of us to discuss on this issue. With this background, I sincerely welcome all of you for this training program. I request my colleagues to take further to have this session of today. I welcome once again. Thank you very much.
So we have Dr. BP Nirmala starting off the sessions. So she has been associated with the Department of Psychiatric Social Work for the past 3 decades, and she has contributed enormously when it comes to rehabilitation of the clients and the family members. Currently, she's working in neurological rehabilitation, and she has been providing services, rendering psychosocial intervention at various stages across the country. And she's also an expert when it comes to disability intervention and correctional social work. So, welcome you, ma'am, for the session.
Thank you. Thank you, madam, for giving an introduction. And I thank Dr. Pandian for giving an introductory note for this particular webinar. Now, the topic is on micro skills in mental health setting. See, human beings are endowed with a repertoire of skills. Some of the skills are inherent. You don't teach a child how to smile, how to cry. They are the skills which are inborn. Right from birth, the child can has got some skills, but there are some skills which you learn them over a period of years. Either you learn by imitating others, by learning through the peers. Peer learning also can occur, or in the classrooms. However it is a kind of capacity building. So the kind of micro skills are some things which you can acquire over a period of time through an expert or through your own clinical experiences. Now, these micro skills have been used in a variety of settings. Anthropologists use the skills, psychiatrists use the skills, sociologists use the skills. You want me to start from the beginning? Okay.
Kindly excuse us, we are just fixing the sharing option. We should be done soon.
From the beginning?
Yes, we can start from here. Because slideshow has happened now itself. Did not come out yet.
So I told you that micro skills are always emerging, and it is not constant. Social work being mental health being an emerging profession, it's dynamic. So the skills also can improvise over a period of time. Now, what kind of micro skills do we adopt in mental health setting? This is the agenda of today's webinar. We have to tell you what are those micro skills which we identify quite regularly in a mental health setting. How often you practice this kind of micro skills, how frequently you use this kind of micro skills, and does the application of micro skills vary from situation to situation? So these are some of the things, because there is nothing like a timetable of micro skills. You over a period of time, I can also include a few of micro skills through a series of through our personal experience, through our practice in mental health settings. So it's not something which is constant. It is like a flowing water, right? Now, the micro skills are many. Why do I say that micro skills in mental health settings particularly is because it is through practice that we are speaking. It is not through textual. It is not through a textbook that we are speaking about micro skills. What we practice in day-to-day clinical setting has been our objective. Now, these skills are very important when we treat a patient. Why I say? Because in casework, you speak that to the respondent as a client, isn't it? And in a business setting, you call them as a customer. But in a mental health setting, you call the client as a patient in a mental health setting. And the person who answers you, it's not a respondent that you call them as a therapist. So what goes on between the therapist and the patient when they use the micro skills? Now, these micro skills have to be used. Yeah. to improve communication. Communication is very important in day-to-day the exchange of information between the doctor and the patient. The doctor-patient relationship can further be strengthened by using micro skills when you are communicating with the patient. Many a times, patients who are admitted in the hospital may not be able to verbalize their complaint. They may not be able to tell what happened to them. The family members also may be so scared. Is this the right person? Have I told the right information? Or at a time, they may not be able to give you the whole gamut of information. Haltingly, they may tell you the information. Or the person who accompanied the patient to the hospital may not be the right person in giving the information. The person who has been taking care of the patient throughout during a stay at home may be a person who has not accompanied the patient to the hospital. So where do you use micro skill? Now, as a therapist, I should have the skill in getting the right type of information from the patient. When the patient comes with a lot of family members, everyone will be jumping to give information. I will give you this information. It may be a chorus of information, and it may be very difficult for us to decipher how to filter this information. Every person in the family feels that he is the unique person, he is a very competent person to give the required information to the doctor or to the therapist. Now, how to tell them that you have to, part by part, you have to tell the information, and you have to educate them well. If you are staying with the patient through his childhood years, you can give us more information about the premorbid personality of the patient. Suppose if you have stayed with the patient during the crisis times, then you can tell how the patient was able to navigate the crisis. How were his coping patterns? What were his problem solving mechanisms? Suppose his mother wants to give you some information, you can how his bonding was with the mother. The spouse can give us information about the marital history. So as a therapist, you should have the skill in navigating through this myriad of information. They'll give a mountain full of information, but you should extract what kind of information is required for the history taking process or the intake. In intake, you may not require a lot of information. It is not a booster dose. At one phase, you will not complete the entire thing. So you can say this much of information is required. The rest of the information, which is very useful, will be taken at a later stage. However, each and every person's information is absolutely important in the treatment of the patient. So the way you communicate with the patient will strengthen. It will build a better rapport with the patient and with the treatment process also. How to involve the patient and the family members in the treatment process, that is also a skill, because the families may not come prepared for hospitalization. They may not know about the rules and regulations. They may not know the duration of stay, what kind of treatment, how much they have to pay, who has to stay in the hospital. So the therapist can use his skills. These are all very important. It's not a textbook that I'm speaking you. It is from day-to-day clinical practice. How you communicate with the patient. It is not like indications and contraindications. You will not tell a list of do's and don'ts. These are the things you have to do when you come to the hospital. No, the way you give the information to them has got a lot of impact about the patients and family members' satisfaction about the treatment. Patient satisfaction is absolutely essential for us to get. We get feedback about the patient, how he feels when he was being treated, how he feels when he was being discharged. So this kind of skills has to be used on and off to get a better outcome. Now, I told you, even in the intake assessment, we require micro skills. Even in the treatment process, we require, and even in the aftercare process also, we require micro skills. Please don't think like micro skills is nothing but a sermon. It is nothing but an advice giving. It is like standing from the pulpit and giving them, a pleasant information to it's a feel good information. No, the skills are something which the therapists use on and off for a better purposeful relationship with the client. This is all very important. Sometimes the family may be dysfunctional. They may try to avoid the doctor. They may not be present to the present in when the treatment was going on. You want some information immediately, but instead they may be colluding with themselves. They may not be able to divulge the right information at the right time, and it is the skill of the therapist to extract the information, giving lot of importance for confidentiality. Sometimes the patients and the family members may not try to leak out all the information with the client. What are they going to do with this information? Is it going to impact the patient's treatment? Is it going to affect us in the long term? So many of the things, some may be real, some may be myths. So these kind of things, to provide confidentiality, at the same time protect the rights of the patient, it is the therapist who has to decide. He has to tell us what kind of skills he has to have. He's endowed with skills, so how to work with the skills, what skills to put in, what skills have to be adopted to bring a better outcome. See, skills are required not just in working with the individuals, even in working with the group, in working with the family members, working with the communities, working with the social service agencies. You require the micro skills. Next slide. And the skills, the first important thing is in communication. I told you, in intake assessment itself, you try to communicate with the patients and the family members. You will also tell them about, patients also always feel that once they are admitted, they do not have any rights. They only have to be a recipient of the services. Now you are the person who are going to educate the client about his rights. So that is also a micro skill. What you people do, we will not give them a list of or a pamphlet or a brochure explaining the micro skill. First you will develop a rapport, and then you will have a skill in providing the information in the right context. Suppose you use a technical jargon. Yes, the admission is this time, this is a high risk, this is a low risk, this is the maximum period of hospitalization required, this much of scanning is required, this much of the other things, the ECG, you all have to go. Family members may not be able to understand the technical jargon of yours. So what they want is, in their local language, speak to them in simple terms, the way they can understand. Don't give them a mouth full of information. Give them haltingly. Every session you have to get a feedback whether they have understood, have they got any clarification. Please don't confrontation is not a micro skill. You try to clarify the information, sometimes summarize the information, conceptualize the information. At the end of every session you try to summarize the information, try to look what is it that that the information that you got this in this session, were you happy with that? Would you like to know more? Would you like to have some clarification on that? Can we meet on some other day to have this session? So this is how you have to work with the patient in adopting the micro skills. There is no textbook. I'm sorry to tell you that there's no textbook which tells. It is your own practice. Through practice only you will know how to use micro skills appropriately, adequately, to get a better outcome. Okay, because this information, I tell you, the information you get from many sources from the family members, but the information should be continuous, should be consistent, constant, and credible. Sometimes the family members may tell the information as though they are repeating anecdote. Or in such a situation, our boy behaved in such a way, and during his childhood, that school somehow, the child did not adjust with that school. So how to tell the family members that this kind of snippets or this kind of anecdotes can be taken up later? What is the burning issues? What is those which are of immediate concerns brought forward, kind of things, no? That can be handled at present. The way you deal with the patient, the way you negotiate with the patient is also a skill, because you should not end up in confrontation. The families are very, very sensitive, I tell you, in mental health setting, because As it is, mental illness has got a lot of stigma and lot of discrimination with lot of difficulties. It's not through first contact they come at the hospital. They would have been a long pathway of care. They would have gone to family physician, magician, here, there, and then finally landed up in the hospital. So you should try to understand the family's fatigue, the mental fatigue, the tiredness, and all. So when you communicate with the patient's family members, it is you should not have very high expectation from the family members. Don't expect all the family members to be verbose, to give all the information. The moment you ask some information, if you ask one question, they should give you 10 answers. Don't expect like that. Our Indian families are not sophisticated, mind you. They require a lot of patience. They require haltingly they give information. Sometimes they become silent. Don't think that they are not interested in the treatment. Probably they didn't understand your question well, or it may not be the appropriate time to give you information on this particular issue. So you should try to understand the emotional reaction of the family members too, in collecting the information. Don't collect the information like a mechanical robot, but try to have a human approach in dealing with the patient. That is what the micro skill says. Micro skill is all about working with human beings, how to improve our interpersonal relationship with the patient, how they can get adjusted to the hospital routine, how can the patient doctor relationship can be better, how the treatment outcome can be enhanced. These are some of the important ingredients for important indicators for micro skills. And I told you, micro skills communication is very important, because on and off we keep interviewing with the client, which some people call as interview. And if it is a psychological thing which takes for more than 2 to 3 sessions, where we deal not only with normal situation but also pathological situation. Then we call them as psychotherapy. Counseling is given even for a normal day-to-day situation also. It need not always be for mental health issues alone. Okay, but don't think that micro skill is something like a machine which turns out pins. No, no. Micro skill, a very sensitive issue. You should have the expertise in using the skills. It is not an advice giving. You do this. If it happens, you can use this solution. It's not the solution which is given on a platter. You should know. It is through your clinical practice that you try to know what kind of skills I had to use. And problem solving, you help them to generate solutions for the problem. Many of the patient's family members, simple problem for you may appear to be very simple for you and me. It was so difficult for madam to bring the patient to the hospital. You may feel, why? House is just 3 kilometers away. There is a bus, there is a car, transportation is available. It is in a city center. Why did it take such a long time? But you should try to understand the family dynamics. There may not be anyone. No one may be interested in bringing the patient to the hospital. No one may be available, or the family members may not be, the help-seeking behavior in the patient's family members may be so poor. They may not ask anyone to give help. They may be self-sufficient family. Over a period of crisis, they may not be able to handle, and they do not want to take somebody's help. So these are some of the issues which, as a trained mental health professional, you should try to understand what is behind it. It is not just patient may speak you one thing, but behind it there may be lot of issues. Person becoming silent. If you are well versed in micro skill, you'll think, why is the person silent? Maybe this is not the appropriate time to ask this particular question, or the person doesn't want to answer, or the person was not able to understand my question at all. And I'm also telling you, because it's a mental health situation, you should always understand the clinical condition of your patient when you adopt the mental health skill. Because sometimes a depressive patient which you are talking, a depressive patient may not be interested to answer. There may be a long silence. He may not be, because of the disease process also, he may not give you a quick reply. Don't think that the person is not sophisticated. The person doesn't know the language. It's because of the disease process. Also, because as a person is depressed, he takes a long reaction time. So whenever you use the micro skills, you should try to first, in a mental health setting, you should understand the clinical condition of the patient. Suppose if it is an affective disorder patient, if the person is manic, he'll tell you all about grandiose delusions that I have a car, I have got a retinue of servants, I have a big house, I can do this, that, I'm a multitasker. Don't take it and say micro skill also one of the skills and micro is empathizing with the patient. So you don't start empathizing his grandiose delusion. That is the reason why I'm telling you that you should try to understand the clinical condition of the patient before you adopt any skill. So when you how do you deliver the skills? And it is not something like a machine which turns out pins, which I have already told you. In your conversation with the patient, when you are communicating with the patient, when you are interviewing the patient, when you are doing some intervention with the patient, you can use the skill as one of the strategies in dealing with the patient. So when you say how does this micro skill, I told you it's a process. So when you meet a patient, there should be an eye to eye contact. Is it not? There should be an appropriate head nod. You should have a sufficient social distance between the patient and the therapist. You should be relaxed, first of all, because if you have 101 engagements and you sit before the patient and every now and then you look at the clock, the patient will have a wrong connotation that therapist is not at all interested in my issue. Goodbye. I'll come some other or a time, or I'll go for some other therapist. So this is not the way in treating with the patient. You should try to understand that patient also has got a burning problem which has to be addressed. So don't take most time is precious both for the patient as well as the therapist. Don't postpone his concern. You try to understand, ask him to explain, address his issues. Okay, let it be a relaxed atmosphere, and don't push the patient too far. Just because you want to complete the intake assessment and within 3 hours you want to finish the interviewing with the patient, don't rush the patient. Rushing the patient is too bad in a mental health setting. Person may speak haltingly, person may not give you information at a stretch. So it should not push the patient too far, because it may create mental fatigue also. So I told you that you should have an empathetic relationship with the patient. You should, in a mental health setting, you tell that you are going to address the issues of the patient. But expectation of the patient will be too high. When they come to a mental health setting, they tell you not only mental health related problems, but they tell you a whole lot of family problems also. But you, as an experienced therapist, you have to decipher the green from the chaff from the grain, you know that. So you should know how to identify the particular issue first. You tell that these clinical things, those things which are bothering to the patient, will be addressed first, and things which are having an impact on the family will be addressed later, because we are interested more in arriving at a diagnosis, in deciding about the hospitalization and the treatment. Then we have to take the concern of the family members as well. So they will have a very high expectation. As a therapist, you should know how the expectation should be commensurate to the patient's problems, to the patient's need, and the kind of treatment. Is it not? If the high expectation just because they have come to a big mental health hospital, you should try to don't. It's how to. It's very easy to say. If he has very high expectation, try to lower the expectation. Is it in a matter of day? Can attitude is long standing, over a period of time they would have developed this kind of aspiration. It's not bad, is it not? When you go to a hospital, big hospital, you feel that at one day itself I should have a solution. So you should be able to convey through your communication skills that it takes some time. Everything cannot happen in a day. No one can give the magic, but how to deliver this information is a particular skill. You should not as though it's a directive. You should not tell them it is a directive that I am telling you, it's an ultimatum that I am going to serve you. No, you are going to convey this information in a most appropriate therapeutic way. This is how you have to deal with the patient. It is only after developing a rapport that these kind of things is possible. So you have to meet the patient on and off, so that the relationship between the therapist and the patient becomes strengthened, and the patient will have trust on you. The patient will listen to you, patient will think that, oh, therapist is interested, he has concern for me, he is giving time. Time is most important. You should be relaxed, you should give sufficient time. Patience listening is the most important micro skill, I'll tell you. Awareness about yourself, awareness about others is also very important, because you see, time is very important. And patient, for him, he is very important. For a therapist, he is one of the many patients. So everyone should feel that the person is given adequate time, adequate importance in the treatment process. So I told you, in the micro skills, there are a lot of skills that you have to use in communication, like reframing. You may have to summarize the whole thing. You may have to conceptualize. You may have to help them in problem solving. You cannot change the attitude of the person. If you have a strong attitude that I do not like this kind of setting, I want to get this done. How much of micro skills can you adopt to bring about a solution? So it is some, all the the kind of skills that you adopt may not be successful, some may be futile at the particular situation, that the skills may not work. It may happen also, isn't it? 100% success cannot be guaranteed by all the micro skills. The way you adopt, the how skillful, how deft you are in navigating through his problems also amount for the success. So you have to keep reinforcing him and get others people's support also to see that the skills are put to better use and they will give us a better outcome. Any others? So I told you, when we use a micro skill, we should never use it like a sermon. No advice giving, no moralizing. No one is in high, no one is low. So you should not constantly compare also, is it not? Comparing. See, this patient is able to give so much of information. I do not know why this family is so rude. Why this family is not able to divulge this kind of information. Every family is unique. Every patient is unique. Every patient has got their own experience. Some may be pleasant, some may be happy, unhappy. So patients and families are very sensitive in dealing with these kind of issues, is it not? So don't compare with them, and don't, and you should also not give your personal experiences every time. It happened to me also. No, this kind of things are not allowed. It's not, it is not, I'll tell you, this micro skill can sometimes be dangerous also. Attaching your own personal significance for each and everything, it shows that you want publicity, you want to be known better. Let us not use this kind of this particular micro skill, because it can be disastrous if it is not used appropriately. And I told you, you should not, don't tell that he feels a certain way. Oh, you're always sad, I know you're not able to talk. Don't try to label a patient. This is most important thing. The moment, oh, you're always lazy, I know you're not able to talk at all. It's good that I asked other member of the family to give you this information. That means you are branding, you are labeling the patient. Please do not do that. And about expectation also, I told you, family will have high expectation. What is wrong in having a very high expectation? Every person wants to feel better, but you can speak to them about reality, what is possible, what is not possible. Please do not give them false assurances. So micro skills, I told you some of the it is used in assessment, it can be used in intervention, it can be used in admission, discharge process, aftercare measures. No matter, in several settings you can use micro skills. How deftly you use depends upon your clinical expertise. There are many skills keep on emerging, you can adapt to the repertoire of skills. But as a therapist, you should have empathy, you should have concern. What you speak should be genuine, it should not be like a textbook. You should come out from the heart. Look, this is the way it is, and this can get better over a period of time. The way you convey matters more. See, you are dealing with human beings, not with robots. And there should be a subtle sense of humor is always essential in micro skills. No, we are not robots, we are dealing with human being. Everyone needs a sense of humor. See, patients, because of the long duration of illness, they would have forgotten how to laugh. They're always sad. They feel that they don't have a right to laugh. They don't have a right to enjoy jokes. They don't have a right to even to see a movie and enjoy. But you should tell them that as a family members, you need not victimize. You need not be a scapegoat so that the patient can improve. If you fast a particular day, if you avoid seeing a movie, or if you don't laugh, do you think the patient can improve? Do you think his illness will come down? No. So no one has to be a sacrificial goat. No one has to sacrifice his happiness, his well-being. Everyone is important. Your well-being counts for the patient's well-being. We want a holistic well-being of the family. It's not the patient is one of the member of the family. If the entire family is cohesive and the well-being is there, it is good for the society too. So we have to explain to them about sense of humor, and the sense of tragic is also there. The family members may tell this accident happened, that illness happened, so they would like to give more information on a particular thing, very less information on certain things. But you should try to, as a deft therapist, you should use your skill. Why these people are giving very less information? Probably they are not associated with the event, or the family may feel uncomfortable with the event to remember, to recapitulate the previous information. But always, my dear friends, I always tell you that don't go on circumstantiality. Don't beat behind the bush, repeating the same thing over and over again. The family members will feel very, very unhappy. So, how to use the micro skill? The micro skill also will tell you how to not to be repetitive, how not to create boredom for the patient, how the don't create distaste for the patient and the family members. Create happiness, create a sense of involvement, a sense of participation from the family members to help in the treatment process. And while using the micro skills, there are also some ethical guidelines. Everything you cannot do. There are some code of conduct. There are some regulation, which is very important in any profession to maintain the sanctity. Right? What is that? The micro skills. You should not discriminate this depending upon the status, depending upon the caste or religion. You should use the skill deftly to each and every individual if it is useful at the appropriate situation, at the appropriate phase of the treatment. And you should focus more on strength for his benefit. Don't go on highlighting the patient's illness alone. A person may have residual deficits also because of the illness, but it is your skill in communicating the patient that you have 75% of goodness, 25% for deficits. So why do you focus only on deficit? Focus even on the strengths that you have. You are a good swimmer, you are a good student, a high achiever, you focus. That is the reason why in the intake assessment, we give more importance even for hobbies and interests of the patient. A pre-morbid personality of the patient are absolutely essential in intake, because we should try to get the portrait of the patient. This is very, very important. And respect confidentiality. I do not want to divulge some information to the therapist. Don't. Some people want to suppress the information because it may be a secret of the family. But what I request you is, don't force the family to leak out some information which they want to preserve at any cost. And you always say and it is for the therapist to convince the family members, to make them understand that you have the competency which is related to the therapy. Okay, you are a good therapist, you are competent enough to deliver the treatment. This is all very important. Thank you. I hope I have given you
Okay, thank you so much, ma'am. After the presentations of all the speakers, we'll be having a session where we can ask questions, and the speakers will be answering your questions. So now it's again our pleasure to have Dr. Damon Queen here. So she, with a combined experience of around 10 years in social work, teaching, and women development and advocacy, she's also an expert in anti-trafficking campaigns, gender and women development and well-being. So she'll be specifically talking about micro skills when it comes to suicide prevention programs. So I welcome Dr. Damon Queen for her presentation.
Very good afternoon to one and all present here. Am I audible?
Yeah.
Yes, yes,
Yeah.
you're audible now.
You're audible.
All right. So I'm Miss Damon. I'm made to be doctor. I've submitted my thesis. I'm waiting for the viva. So thanks for all the blessings that people have called Damon. And today we are going to look at micro skills for suicide prevention program. I think this program has been ideally planned in the month of October, because October is a month of World Suicide Prevention month. And before looking at what are the micro skills for suicide prevention, so I'll be touching at my presentation will focus on these areas to set a context about what is suicide and magnitude of the problem, and what is the global statistics. So where do, as in India, as a country, where do we stand in the suicidal rate? And what are the risk factors that are associated with suicide, and what are the warning signs? And it's very important for us to understand what are the myth and fact about suicide. And broadly, I'll be discussing about the micro skills for suicide prevention. So when you look at the concept of what is suicide, the word suicide comes from the Latin word su means oneself and cede means killing. So when you look at that, it is a conscious decision made by the individual to kill themselves, to end their life. So suicide refers to an act with a fatal outcome that is deliberately initiated. So they consciously know about what is the consequences and what they are doing. And when you look at the global burden of suicide, it's not only an individual decision, it's not only the individual problem, it's a serious public health issue, because it's highly preventable. And why suicide is very complicated, because there is no single cause, or there's no single reason behind, or when you look at what is the rationally behind, there's always complexity that are attached with it. It can be biological, it can be psychological, or it can be socio-cultural, or it can be the environmental triggers, or it can be the combinations of altogether. It's very imperative to understand that when working with suicidal people, know what is the one of the trigger factor, or why is that, when you look at, the problems are inevitable. People throughout the globe experience a problem. How is someone able to survive resilient and move forward in life, even when they're stuck with issues? How they are able to understand the issue, bounce back and move forward? Why are certain people stuck and they quit life? It is so complicated in its to understand, but it is highly preventable. If suicidal ideation is prevented at the identified at the right time, if interventions are given, it is 100% preventable. And when you look at the suicide, what is the magnitude of the problem? There are two things that we need to understand. People who commit suicide across the globe, it is 8 lakh people. So every year we lose to suicide. And people who attempt suicide are the one, they make number of attempts, but they fail in suicide. And for every 40-second person commits suicide somewhere in the world, for every 40 seconds, someone is dying because of various other issues, and it could be preventable. And when you look at what is the statistics of people who are attempting for suicide, it's for every 3 seconds a person try to attempt suicide. And when you look into the gender lens of it, men are the one who succeed in suicide, whereas women, the one high try. The number of attempts taken by people who are attempting suicide are women. And when you look at what the common methods of attempting suicide, it could be the injection of pesticide, hanging, firearms. So it could be any other reasons, any other modality that they are adopting. But as far as nation of India is concerned, the top 3 are pesticide, because we have the agrarian population. A lot of suicide happens in those regions. So pesticides, taking of pesticide is one of the reason, one of the method, and number 2 is hanging. For each suicide, there's a serious impact that it's not only, as I said, suicide does not really affects the person who's committing it. It also affects the loved ones around. So statistics and a lot of the research says that it could at least have a very greater negative impact on the close 6 person who are around. So it could be their family members or friends. So when you look at, the suicide could be vulnerable for any people from across the lifespan. It could be the children who can be, or it can be adolescent, or it can be elderly, or it can be women. But it says that statistics says that the adolescent age, especially adolescent to youthhood, 15 to 29, who are the high risk for suicide. So these are the people who attempt suicide, and they also end up in committing suicide. So when you look at the global statistics where India stands in, and you see that in 10th, so suicidal rates are high in India, and especially in South Asian countries, you see that suicidal rates are really high. And when you look into the gender lens of what is the global statistics of suicidal rate and where does India position in that, India actually exceeds the global standard. So India's suicidal rates exceed the global range. So when you look into that, the global range in 2016 for men, it is 15.6, whereas in India, it is 21.2. And whereas for women, the global standard is 7, whereas in India it is 14.7. So it is high. So when compared to the global standard, so there's a greater need to talk about suicide. People think that talking about suicide is a bad idea because it might give an intrusion to others, it might give an idea to others. But the fact is, talking about suicide can give them, elevate their pain. It can give a scope for people to talk about the pain that they have. And so it's very important to, as an educators, as an academicians, or as a practitioners, talking and reflecting on it. So again, when you talk about the Indian statistics of NCRB rate, so every year it is always from 2017, 18, and 19, you look into the statistic, it says that no, we are losing 1 lakh population due to this preventable suicide. So this is not a very fact that can be acceptable, but it's very imperative that, how as a multidisciplinary team that we collaboratively work, it has to be seen as a serious issue. Because now looking into the pandemic, across the globe, you see that there are about 1 crore people die of COVID, and that's become a very serious issue. That's a communicable disease, and people are panicking about it. But somewhere that concept of suicide has been taken very lightly, because it is not the number of suicidal rates are not reported in the newspapers, highlighted in the medias. So not much awareness are there about suicidal rates. And when you look at on an average, 381 people die of suicide, so which is alarming. And again, when you look at the suicidal rates in the city, especially in the metropolitan cities, it is 13.9%. So it is higher when compared to the rural population. Why suicide prevention, especially being a mental health professionals, why it is very important? Suicide prevention is a global protocol. When you look at WHO's Mental Health Gap Action Plan, which was launched in 2008, it has been mentioned that suicide is one of the priority condition to be noted. And they started working on MH a gap plan in 2008. And again in 2014, when you look at the first WHO World Suicide Report, it exhaustively talks about, very imperatively talking about, as a mental health professionals, our protocol is to focus more on suicide prevention programs. And again, when you look at that report specifically says that higher priority should be given on the global public health agenda, that suicide is not just one of individual concern, it is a global and a public health concern. And again, when you look at in 2013 and 2020 World Mental Health Action Plan, the WHO members stated that it is very important that they have set a target, that the global target of reducing suicidal rate in countries by 10%. Now things are due to this pandemic, things are little outside the control. So the reports are not yet out. We don't know how much as a team, as a globe, we have worked on in reducing the suicidal rate. And in order to work in the prevention program, it is very important to understand what is the mindset of the suicidal persons. There are 3 different perspectives that I would like to give. What could be this mindset? Say, for instance, one is the ambivalence. What is ambivalence? There is a myth about suicide that people think that, people who wants to commit suicide have a very strong, determined plan about committing suicide. But the fact is there is a component of ambivalence, because people who have suicidal ideation and they wanted to commit suicide, they have the mixed feeling about committing suicide. They are on the cat on the wall. They wish to leave and they wish to die. When you look into their closer look into what is their understanding, they really wanted to elevate themselves from the pain. It is not they wish to die, they really wanted to elevate themselves from the pain. It could be the pain of some physical illness that they undergo, it could be the pain of some financial crisis that they undergo, it could be the pain of any relationship breakdown that they undergo, it could be the career downfall that they undergo, or it could be work pressure. But they really wanted to elevate themselves from the pain. It's not they wanted to die, but they think that there is not much option. So that's why I said it is an ambivalence condition. So they have a zigzag feeling, the mixed feeling. So there is an urge to get away from the pain of living, because for them, living with that issue of any crisis is very painful. They wanted to elevate themselves from the pain. So this is a typical mindset of majority of the persons who have suicidal ideation. Number two, impulsivity. Again, impulsivity, suicide is also an impulsive act, but still the suicidal ideation can be predicted. The ideation that the individual have, if they have any crisis, suicide is an ideation. If they have said that as a perspective, that could be easily identified through the intervention processes that we work with. So while suicide being an impulsive activity, the impulse to commit suicide is very transient, and it lasts for a few hours. People think that when people have the suicidal ideation once, they might remain throughout the life, that ideation. Not necessarily. It's just whenever they have the trigger, if they have the certain ideation developed before, if they have definitely seen somebody committing suicide and elevating their pain, or they have said that suicide is the only option in their mind, some triggers can help them in easing that impulsivity. So it is usually triggered by the negative events. Higher the negative events, higher could be the decision towards committing suicide. So when we are working in the center, how are we going to identify what are the negative triggers that they have, and elevating that can ease them to come into the normal situation. And third is talking about the rigidity. It's again complexity. One side you talk about ambivalence, one side you talk about rigidity. Rigidity is that when people are suicidal, their thinking and the feeling and the actions are constricted. They think that in order to elevate from the pain, they would have said that ending their life is the only option. It's the only option. So they're not able to ask for others for help, or probably they would have asked for help that they wouldn't have got it, or they wouldn't have had a trusted person where they can share it. So this is where the rigidity, they think that in order to overcome this financial crisis, this is the option. If the debt level is high, this is the option. If the physical pain is really high, or if there is a negative report that they received for their loved ones or anything, they think that they're thinking and everything is constricted, so they don't ask for help. They constantly think about suicide and they're unable to perceive other way out of the problem. So this is something about the three angles that we need to look at. And again, when you want to work in a setting, it's very important how we identify, assess and manage and refer them to the health center. Now we are going to look at what are the micro skills. Very important. I'm going to, NIRMALA ma'am has a set of context of different micro skills. I'm going to precisely talk about 5 to 6 different micro skills. This micro skills is not only necessarily working in suicide prevention, it could applicable in any kind of a health setting, and predominantly it could be in the areas of mental health interventions. Number one, listening, active listening. And active listening establishes, very important that it could be established during the good trust, during the rapport building stages. And most importantly, in active listening, it not only builds the therapeutic alliance, but also client feel that active listening, it also gives a sign. It also gives a sign to the client that you're listening to them, you're also understanding their feeling. In a way, you're also telling the client that you're respecting them. Listening. So in counseling, we always say it is 80-20. So it is 80% of listening and 20% of talking to them. So listening, and majority of the time, when you look at why listening is so important, people have this impulsivity, as I talked about suicide. So there is a natural resilience. if the mind is full of confusion, there's a lot of insecurities about their life, there is a lot of threat is there. If they really have a good platform to express their emotions, express their feeling, when everything comes out, the process we call as catharsis, then if the movements can be lighter, then they can have their own solutions to that. Problem with majority of the people who have suicidal ideation is they don't get a good platform to talk to people, or in a way I can say that they don't get good listeners whom they can share their problem. And again, when I talk about listeners, they are active listeners. When I say active listeners, who are not very passive about it, we are very active and without having any judgmental attitude. So very feeling. And when we talk about active listening, there are three things. As I said, suicide will always comes with a lot of people. Ideation will have a lot of warning signs. It could be the verbal markers. So when you have to talk about verbal markers, it can be the talk. Say for instance, they say that constantly say, they might say that I feel like killing myself, and I don't want to be a burden to others. I don't think so. There is no reason for me to live. I think I've been feeling trapped. But what do you see in contrary? People say one of the myth about suicide is people who talk will never do it. But the fact is, when they in suicide, when people talk about it, they are looking for people who can listen to them. They wanted to know whether anybody is interested in listening to them, and anybody interested or anybody have a contrary thought about it. So when people talk, give those verbal markers, this shouldn't be taken at a very light sense. When people say it could be simple talk, they can say that, I don't think there's no point in living. And whenever they talk, there are two things that you can observe. One is the talk, which will always associated telling them they are not worthlessness talk. And number two is about hopelessness. They talk about these two things will be in it could be in different forms that they could express it. Somebody would say that there's no point, nobody loves me, so I don't want to live. So it talks about they don't think that they are worth enough. Or I think that even I'm going to work for another 2 years, I don't think so I can build up this financial position. It talks about their hopelessness. So these two things, feeling worthless, they're not worth about it, and again doesn't have good hope and hopelessness. These two situations are the good of the verbal markers that you can look for the warning signs. And number two, when you're talking about the warning signs in the behavior, withdrawal of activities, it could be suddenly. Both the ways you can say. A lot of statistics says that there are certain people who have the strong suicidal ideation. By personality, they could be very introvert. By when they have the personality, when they wanted to commit suicide, probably that's where they open up. They go meet friends, they meet relatives. So sudden withdrawal of behavior. It is not whether they wanted to either by being very passive they can be active, or by being active they can be either ways around. They wanted to end their life, but they wanted to go meet their friends. Suddenly they can be very highly socializable. It could be one of the reason as well. So when you look at that sudden change in the behavior, that could be one of the warning signs. Again, say for instance, as I said, in the initial, adolescents are the one group that is highly prone for suicide, high risk for suicide. You see that actively, recklessly driving, so rash behaviors. And again, when you look into the sleeping pattern, either they sleep too much, they wanted to be in their isolation, they wanted to be alone, and they wanted to withdraw themselves. They doesn't want to talk. A lot of aggression. They are aggressive. It might be expressed in the form of words, or it can be expressed in the form of actions. It could be intake of drugs, alcohol. So these are all the sudden change in the behavior that could be observed. And again, the warning signs could be expressed, or when it is expressed, it can be felt only by the loved ones whom they are close, or the person whom they communicate very closely. It could be their family members, or it could be the peers. And when we talk about the warning signs related to mood, it could be symptoms related to depression. They feel very humiliated about it, or they keep talking about that. I don't know what is going to happen in another 10 days. Oh, this notice has come. I don't know what are the. So they felt they will lose a lot of. So it's a combination of all. So when you talk about depression, it can be expressed in the verbal form, or the feeling of humiliation. They can express it out. Irritability, lot of losing the interest in anything that they could do. Feeling of anxiousness. And when you look into it, there are certain concrete signals that they might give it to you. So for instance, one of the signal that you can identify when you're working with them. Earlier attempt of suicide, it says that 10 out of 7 people who try attempting suicide, the earlier signs would always be present, or either could be the instant of self-harming, hurting themselves, banging themselves. All those would have got over a period of time so rigor, and they would have got this suicidal ideation. So identifying the earliest symptoms of suicidal attempt is one of the risk factor that is associated with suicidal ideation. Anxiety and panic, withdrawal of behavior, so sudden withdrawal from the family, friends. And then you see that one of the very critical thing that you understand working with them, self-hatredness, feeling very guilty, as I said, worthlessness, ashamed. So a lack of self-love, you would see. If at all there is a self-love high, then definitely there is not an ideation for them to commit suicide. Though they hate themselves, they have a lot of regrets, that they have feeling of guilty, that they have not contributed something, they have not achieved something, they don't feel that they're worth to live. And this is the common symptoms that you can associate with suicidal ideation persons. Next, when you look at family history of suicide, as I said, when you talk about the adolescent suicide, so definitely it could be the environment where they would get a lot of ideas about suicide. It could be the family history of suicide. Somebody in their family would have attempted suicide. They would thought, okay, in school somebody bullied them or something happens to them, they think that okay, that's the solution, because if they're the fragile age, they're not able to take it up, so they might end up in it. So it could be the media, because media nowadays is a greater influence. So we should media gives a lot of influence for the young children. So it could be the influences from outside. And again, talking about the idea, how do you identify the suicidal notes? Some people write the suicidal notes about it, and then repeated mention of death or suicide to somebody else and feeling of loneliness. And when you talk about it, these are all the risk factors. There's a difference between a warning sign and the risk factor. Warning sign are the concrete signs that people having the suicidal ideation. But the risk factor, it could be the general population. But this is the general population needs awareness about suicide, because anywhere down in the line, they could fall under the category of attempting or committing. So for instance, people who have physical disabilities, so they are a high risk for suicide. Number two, any loss in the relationship, losing a friend, the family members. Again, as I said, exposing themselves to bullying, especially that happens during the age of adolescent and youthhood. Any severe mental health conditions, or losing any of the relationship, access to any harmful means. All these are the combinations of the other factors which make them very risk for suicide. I mean, one other micro skill that is very important in working with suicide prevention is questioning. Understanding the client effectively through questioning is very, very important. The questioning, when we talk about questioning, it's not only the initial stage, we question them a lot. We use this micro skill of questioning to understand the patient or understand the client, understand the person. But throughout the process, it is very important, because, throughout the process, we need to keep asking. So I'm going to give you some debriefing understanding about it. Let's say to find out whether the person has a definite plan to come into say, let's say you're working in a clinic and you have a person who has an instant of self-harm coming, or attempted, you're in a crisis care, they have come. So could be a very direct question. Have you made any plans to end your life? Do you have any plans to end your life? People have a myth thinking that asking a direct question can give them a lead. No, asking a direct question, because when we work in a crisis center, when we are working in the crisis call, we have very limited time. The time frame is very, very crucial. Instead of asking too many things, the questions can be really, really direct. So have you made any plans to end your life? Or it could be the questions like, do you have an idea of how you're going to do it? Do you have, because sometimes people say that I really want to kill myself, I really want to elevate. When you ask them, they would take time to think, which means they did not have a concrete plan about it. So in that case, you have a breathing space, so you can slowly work or identifying what is the rationale behind it, slowly working on the problem solving process. If they clearly have a plan, they say that, yes, I have bought the pills, or I have a knife, or I have set the rope at home, then you have very little time. So if you are a trained person, you can directly work on, or if this case has to be referred to the mental health center. And when you talk about to identify the plan, you have asked this question. In fact, if you have identified the person has real plan, then the next question should be related to asking what is the mean. To find out whether the person has got any means or method, the question could be again still very direct. Do you have any pills or rope or insect? So how are you going to do it? You're saying that you wanted to end your life. So tell me, how are you going to do it? So have you made any plans? Is it really readily available to you? So these are the question will help us to understand where in which range the patient is. Based on that, our response should be there. It should be very, very assertive in communication. And third, so if you have identified what is the plan that the patient has or what is the person has, number two, identify what is the means or the method. Number three is the time frame. Very, very critical, because to find out whether the person has a fixed time, certain people will have fixed time. They will say that, remember working, got a crisis call 4 years before. It was for talking about call inquiring about organ transplantation. Person said, the other side, the person said that, madam wanted to know whether I can donate my organs. I said, like, okay, you can donate your organs. Which is the organs you want to say? That I'm going to commit suicide now. Within how many minutes I can donate my organs? So I think the time frame is very crucial. There you cannot do any minute. So that person has to be reported to the emergency, either to the identifying the location, and the police has to be informed. And again, the medical team has to be informed. There you don't have enough time. So in that time, very important, once you identify what is the plan, what is the method, then you identify what is the time frame. Ask a direct question. Have you decided when you have planned to end the life? Because certain people will say that I really want to commit suicide, but I know I want to visit my children and I wanted to set things out, or I wanted to write a will, so about or I want to settle up certain things. I have issues in my office, I want to settle up this, or this person insulted me, I have to prove himself that this is wrong, and then I want to end. So they would have certain time frame in that. Very, very important. Identify whether they have any plans. Number two, identify what is the means that they have. And number three, time frame. So when are you planning to do it? So you can ask them. And on a third important micro skill, this micro skill not only for suicide, it is for any program that, or even that, I would say that's one of the life skill that's very important. Empathy, understanding person's feeling. And this word empathy is very, very crucial for all social workers, I believe. And say, for instance, when you work with a client, especially when you work in a setting like crisis care, a lot of emotional involvements are there. What happens, instead of feeling for the client, the worker most of the time feel with the client. There's a lot of difference between feeling for the client and feeling with the client. So when you feel for the client, you still have your professional boundaries, but you still have the emotional connect. All right, you have the working ethic. But when you feel with the client, you also more close to the client emotionally, and you stop having that emotional boundaries with the client. And especially when you're working with a client in a crisis care like suicide, very important empathetic understanding. So when you have empathetic feeling for the client is so important, but you should consciously don't feel with a client, very important. So empathy, as I said, your ability to imagine oneself. Say, for instance, sometimes when you work with a client, one client comes a serious issue and want to commit suicide. Some client come, it's because they have an issue in the organization, they want to end up committing suicide. So understanding the client, each person have got their own capacity to understand their situation. For some, even if it is grade 3 level problem, they can take it. For some, even if it is a small issue, they're not. For them, what is that? What does it means to them? Understanding them is so important. So when you're working with a client, there are two things that you need to understand empathetically. Is it a concept of self-harm or self-suicide? Most of the time when you're working with suicidal patients, you will see the component of self-harm. So it's very important. So what is the difference between self-harm and suicide? The frequency, the incidence of frequency are high in self-harm. Say, for instance, they would be repeatedly. Say, for instance, whenever there is a trigger comes, say for when there is they face any discrimination, or when they face any hurt, every time, or when they would have faced a discrimination once, or faced any kind of a hatred once, every time when they sit in their room, think about themselves and wanted to ease themselves, they just cut. So the frequency is really high in self-harm, whereas an attempt, the frequency is very low, very less when compared to self-harm. Again, the method, it's always cutting or burning themselves with a candle or a light or something, self-hitting, banging themselves. So these are all the methods, whereas attempting is more a higher degree where they wanted to poison themselves. Severity is very less in self-harm, whereas in suicide it is more severe, and it can sometimes lead to, most of the time it can lead to death. And purpose of self-harm, they're done only to avoid the suicidal impulse, whereas here there is a concrete plan that they want to die. And very important, when you have a client, when you're working in a crisis center, when any instance of self-harm is entered, it need to be given important. It need to be given necessary attention. Ask them if there are a lot of cuts are there. Ask them why first cut, what was the trigger, second or third, is there a similar pattern? Because suicidal, it's a lot of patterns are attached with that. So because they have this ideation, they think that if everything happens, it is their self. So hurting their self is somewhere that you feel that, they did something, justice to something that has happened. It could lead them to the greater level of ending their life as well. Another thing working with a suicidal patient is communication. Very important. It is very important to have a very clear communication. Again, I talk about the myth. People say that, when they have the suicidal ideation, the communication, you don't tell them exactly what happens, or you don't tell the family member. The communication has to be very straightforward. Very, very straightforward. Say, for instance, when you're working with a client, there are some do's and don'ts about communication. Number one, talk honestly and genuinely. Let's say when a client comes and the client says that this much of physical pain that I am undergoing, so I really feel like killing myself. Be very honest. We cannot say that, oh no, 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 all the pain will be gone tomorrow. That's not practically, or we don't know what is happening. Say that, this is what you might undergo a pain, but these are the things that are being taken care. All right. So talk honestly and be very genuinely. Why? Because if they have come to you, if they have come to the crisis center, if they probably, there could be a lot of chances they would have contacted their friends, contact their family members. All those would have been, not much have been professional. All those unprofessional would have said the same thing. Don't worry, everything will be normal. If as a professional you're going to tell the same thing, I think there the trust is going to broken. So talk honestly and be very genuine about what is the situation, and listen attentively and be calm. So these are the things about those. And number two, when you talk about it, express the respect for the person, opinions and their values. Say, for instance, even if they have said that, they wanted to commit suicide, we don't tell them that's a good idea or that's a bad idea, but tell them that this is the consequences. I understand this is the pain that you're undergoing, but after that, you think that the pain is going to come to an end? No, it's just the person is going to die and the pain is going to continue. It doesn't stop with one person. The pain is going to continue, the depth is going to continue, or the financial crisis is going to continue. Earlier it was just only the financial crisis, now only the human crisis also, the death of the loved one is also there. So talk about so not criticizing about the decision, but tell them what the decision that they made is a bad decision, but do not criticize about it. Accept, respect them. Number three, understanding person's feeling. As I said, empathetically understand why they made this decision. Sometimes remember talking to a person wanted to had a very strong suicidal ideation because one of the trusted friend has cheated them. It was in an adolescent age. Probably that wouldn't have been a very major issue for a bigger suicidal issues, but for that person it is a hurt. It is, for that person, they wanted to end their life. So understand that person, what it means to them, understand them, and then give non-verbal message of accept and respect. As ma'am said, elaborately, ma'am has explained about a lot of gestures, and so I'm not going to go deep into it. And then show your concern, care and warmth. Focus on person's feeling. Ask them what it is. I want to kill myself. Ask them why you wanted to kill yourself. What happens to you? What happens to you? Ask them about feeling. Let them express their feeling out. If this person spoke to me this way, when the person spoke to you, what had happened to you? How did it affect your feeling? Elaborately. Most of the time when they're so much in their mind, when there's a space is given for them, when they talk, it can lighten, it can also give a space for them to revisit their decision that they have made. Very important. So focus on the person's feeling, listen and be empathetic, and then being supportive. We will focus more on what are don'ts, what are the things that we do not, is not supposed to do during crisis counseling, especially working in suicide prevention. Interrupt too often. If their stories, especially when there's so much in their mind, they wanted to tell everything, don't interrupt too much because the flow gets affected. Let them say. Sometimes, when you're working with a client, we know about the worker client, the percentage of ratios of how many people, the burden of patients that we have. It's critical, but it's very important because that tells that we respect them, and we are carefully listening to them. Do not ask loaded questions. When do you want to do it? What happened? What did this person? Let it go in a flow. Let it go in a flow. So asking too many questions, that can stop the flow. Number 3, very important, being do not be very shocked or emotional. Oh, this has happened to you. Oh no. So all this question, all these things can actually give a negative feeling to them. Or sometimes if they're already negative about it, it gives a reconfirmation, negative reconfirmation from your end. Okay. So I also felt this way only. So very, very, do not be very shocked or not give very emotional embarrassment or giving panic about this. This is what happened. So one of the clients said that during it was next day, all big wedding has been set, but the groom has just escaped. So in those cases, natural to give a shock, but if you do it the same that person, because already the negative energy is running and you're reconfirming that with the client. So do not do that. Sometimes conveying that you're too busy and ignoring the situation. These are all the communication strategies that we should not do it, especially working in a crisis center. And challenging the person to go it. Sometimes, when you're working with a suicidal ideation persons, it's not in one sitting that they get convinced about the decision. So you repeatedly spend the 30 minutes of the talk, end of the 30th minute, they still talk, you do all the conversation, then they say that, it's okay, ma'am. However, I spoken anyway. I think that I am, there's no worth in living. Do not give up. Do not give up on the client because we are not. We are called to work for them. And in case if you're not competent in that area, please refer them to the mental health professionals. Challenging the person. Okay, I have told whatever I did. Please go and do whatever you want. No. That is not the place where we can show up our own emotions there, our own because we have this long burden of working with them, and even other there is no outcome that we expect doesn't mean that we can show up their anger or show up our challenge to the client. Making the problem appealing very as if it is so simple, or giving a false assurance. I said no, never give a false assurance, because when people come for the suicide prevention center asking for a help, definitely you're not the first person that they have communicated. Definitely they would have given the verbal markers to their family members or the loved ones. Whatever the fake assurance that they have given, they're not convinced about it. That's why they are coming here. Let's not give the fake assurance. Be very practical, be honest, and talking about it. And then very important to understand what are the myths about suicide. As I said, talking about suicide, people think that it's a bad idea, but can be interpreted as an encouragement. No, it's a good idea. Thinking about suicide, it can give a platform for people to express about it. Someone who's suicidal is determined to die. It is not they are determined to die, but they have strong determination to end their life, end their problem, elevate their pain. So they choose suicide. And number 3, people who talk about suicide do not mean to do it. People think no, whenever they give verbal markers, when they are vocal about it, then they will not do it. That is a total myth. People will be looking for people to share about their problems, and they would express in a verbal markers or emotional markers. Only people with a mental health disorder or suicide can happen to anybody else. It's just about the trigger. And most suicide happens suddenly without a warning. People think that it is neither preventable nor predictable. It is highly preventable when it is predicted at the right time, because though suicide can be in certain cases impulsive, but the suicidal ideation can always be assessed. It can be predicted so that it can be prevented. Again, when someone is suicidal, he or she will always remain suicidal. No. Say for instance, if this is pressure, they had the suicidal ideation, not necessarily they have to remain throughout the life with us. So these are all the myth about suicide. And the last micro skill that I'm going to talk about is observation. Very important, taking the situation very, observation helps the client or the worker to take the situation more seriously and assess the degree of the risk. As I said, some will be in the planning stage, some will be just having the ideation, some will be in the planning stage, some will be having set the means, some will be really set the time frame. So observing in which stage they are, based on that our interventions, based on that we need to do the referrals and everything. And client observation, when you look at the client observation, it is very very important. It helps to identify all the discrepancies in the life, and our body languages are very important, tone of voice, our facial expressions very important. There are a lot of emotional markers are there for us to observe. Feeling very depressed, lack of interest in the activity once they could have enjoyed. All right, so irritability, anger, and anxiety, shame, they feel very shame about it, they feel very humiliated, mood swings, these are all the emotional markers that you can see. Verbal markers. So again, when you talk about verbal markers, there are two different statements. Both the statements need to be looked into carefully. One is an active statement. Active statement can be very very direct. I'm going to kill myself. All right, so the passive statement is, I wish I could sleep and I don't get up later. I wish, the world ends now. I wish that, something happens in the building that I get collapsed. So it could be active or it could be passive. What happens is, most of the time we give more importance to the active statements and we leave out the passive statements. So when you're working with a client, especially in the mental health setting, lot of passive statement that you know. So when they talk about this passive statement, take time and ask them. Ask them. So you were talking about, that you wish don't want to wake up or you don't want to see them. Why do you say that way? Elaborate on that. So a lot of passive statements can be a lead. Probably they don't know how to communicate, or their personality is that they don't communicate very straightforward. So both active statements and the passive statements should be looked into. Those could be the verbal markers. And again, some of these statements could be including killing themselves, that they think that there is no purpose in life, they are not, they feel that they are burden to others. They sometimes they'll say that no, a person should live only till the age of 50, after that there is no worth in living. So that could be a passive statement. That could be ask them, why do you say that way? Why do you say that way? So this could be the passive statement. They are feeling stuck about it, they're not able to move forward because they feel very insecure about their future, and they doesn't wanting to exit as well. Lot of behavioral markers that you could observe, and some of the behavioral markers that you see in the slide, they don't communicate frequently. Social withdrawal, you will see that they doesn't want to sweat. And another behavioral marker, you could see that highly they can, now you see recent suicidal, you see that Instagram, in the Instagrams, in the Facebook, they have openly said that they doesn't want to live, they doesn't want to. So it can be either way. It can be they wanted to openly communicate that they wanted to die, or I don't think that my fans still love me, I don't think that I did justice to the role that has been given to me. So these are all the passive statement that they have given. It could be either ways. And sometimes behavior markers, driving recklessly and increased aggression. Sometimes it is more rigor in the elderly, giving away all the possessions or writing a will for the family, settling all those things. Or sometimes they wanted to visit their the holy places that they wanted to do it, or sleep. And these are all the markers that you will see, gathering materials related to their settlements and everything. So when you identify, when you're using the micro skills, identifying what are all the suicidal ideation that they have, it is very important that we respond to them immediately. I just got one few points to say. When you are identifying, when you have a person, stay with that person, never leave the person alone, inform the family and enlist its support, gently talk to the person and remove. When you identified, is there any risk factor associated with they have this means, kindly remove it. And if you're a trained person, be with that person and do the intervention. If not, kindly refer that person to a mental health professionals or call to the tele centers. Yeah, thank you. So I'll be waiting for the questions.
Thank you so much, ma'am. It was an elaborate presentation, and we got a lot of information about how, specifically when it comes to suicide prevention, how the micro skills can be used. So, thank you so much for that. Now we have our final speaker, Dr. T.R. Kanmani. She has been working in the medical social work setting for over 3 decades now, and she has worked extensively with HIV/AIDS under NACO, WHO, KHPT for training development of manual and technical support. And currently, her area of clinical service is psychosocial intervention for road traffic accidents, injury, spinal cord injury, brain tumor, cerebrovascular disorders, psychosocial support programs for caregivers and trauma care. So she will be talking about microskill practice in medical settings. So yes, over to you, ma'am.
Thank you, Lakshmi. I think I may not take more time because it's been elaborately already explained by the previous speakers, Dr. BP Nirmala and Damen Queen. So my focus is basically going to be only with medical setting. So far, wherever we have been posted or the social workers who have been practicing in different sectors, like in India, medical social workers are working predominantly in cardiology department, organ transplantation, TB and chest, skin and STI, and virology after a lot of pandemic which has come, especially HIV/AIDS, and emergency and trauma care, and at NIMHAN, especially neurology and neurosurgery setting, and also plastic surgery, where with the burns patients, where many of our social workers have been widely working, and nephrology is the other concept which has been going on, and the age-old work what we have been doing with the cancer hospitals and diabetology recently, and many more very mild form of areas like ophthalmology and then ENT. These are the places where social workers work in a different different work by nature, or different work which they perform. So wherever they have been working, the micro skill is an important component and it is also like when we are providing a counseling sessions for all these patients and their caregivers, the micro skills plays a major role. Now, if you look at in the medical setting, we basically use 5 micro skills in a large spectrum. The first micro skills, what we basically use is an observation skill. And we also use an active listening, which comes under the communication skills in a broad spectrum. Use of questioning, which is very, very important in many of the medical setting. And use of silence is extremely important in many of the medical social work practice with the grief and also with breaking bad news. And so at times, use of humor is one of the very important micro skills practice what we use. And of course, everybody has used empathy. So these are the major micro skills which has been used day-to-day basis along with all the other skills. But these are the major skills which we use in the medical setting. Now, if you look at like I'm going to talk only in the 5 broad spectrum with the cases, whatever I have seen and how the skills which has been used. Now, if you look at, 1 minute. Now, if you look at micro skills treatment in treatment adherence, this adherence is extremely important area when we are dealing with chronic clients or patients with the chronic diseases or diagnosed with the chronic phases, and even palliative care where patients require treatment adherence. So treatment adherence, all of you know, it's basically very important for the patient to sustain taking the medication and also continue to live well and healthy. So when we are providing or when we are doing a treatment adherence counseling sessions, we basically require an observational skills. And we also need to listen to them of their stories, what they wanted to talk to us and express to us the difficulties, and also what is the different issues with the cultural perspective, what they have been facing of not able to have an adherence. So while we are providing a counseling, like especially in HIV/AIDS, patients with a different kind of cancer and patient with kidney failure or taking treatment for kidney or chronic kidney diseases, and patients who are suffering with trauma or brain injuries, or patients with a tumor or patient with multiple sclerosis, or patient with a different kind of chronic illness. Okay, these are the patients who require a treatment adherence and who need to take treatment very regularly, and now and then they need to be monitored. So when the patient comes back to us after a period, say around 6 months or 1 year, when they have not maintained the follow-up, and when they come to us, many of us tend to scold the patients, especially treating unit, because it's not that they wanted to scold because they have a free time to scold these patients. Their concern towards the patient, which has been expressed in the form of different mode of communication. So when these communications goes little bitter, or they are not able to provide in communication or not able to provide time, these patients are referred to the counseling unit or psychiatric social work unit or a medical social work unit. So when they come to us, we need to use a listening skill, especially to listen to their stories, because unless until you listen to their stories, you do not know why they are not able to follow the treatment in a proper manner, why they are not able to come for the follow-up. Sometimes people, the medicine would have been over, which they would think, okay, 1 day or 2 day, it's okay, chalta hai, so I can go and take tablet after 3 days or 4 days. Why there is a lag behind, why the patient has not understood. So that we need to understand, and then provide an education about why it is important, how it is important, how even when they have a cultural practices, how well this medication need to be taken. All this which we need to look at it, and based on these slides what has been put up, so we need to tell them about how to sort out the pills. And there are also boxes which is available with the morning pill, afternoon pill, evening pill, which they can carry always, and reminder alarms. And they can also have a telephone support groups, where some of my patients have been practicing that. Like they have a group members, they have a time set, so the alarm will ring in the group, so which keeps reminding them. That's one form of a group, one of the patient population who has been diagnosed with a specific disorder. There is another group, each one will complement, and there will be a group leader every month. This group leader main role is to provide a message stating that this is the time for them to take the medication. And there are various other methods which has been utilized. So micro skills are extremely important, even to provide even to provide or support treatment adherence in the medical setting. Now, if you look at the other aspect of it, health. If you look at health is a broad spectrum, as we have discussed now. The first one, when you look at health per se, HIV/AIDS, and you also have a gynecological issue, you also have infertility related issue, you also have got people with different kind of ailments like diabetology, rheumatology, and hepatitis, and people with blood groups related disorders. And they also have got acute phase or sometimes even subacute phase, and cancer and various other lifestyle illness what has been happening. Those people also need lot of counseling, and who's been diagnosed. Like nowadays what has been stated in the medical setting is, earlier the moment they have been diagnosed with a medical illness which is going to be chronic lifetime, it has been considered as like, the doctors will treat, they will come for the treatment, and palliative care will be taken later period or end of life care. Now everything starts at the time of diagnosis. So the moment the patient has been diagnosed, in the counseling process we need to start talking about every aspect of their what is diagnosis, what does it mean, what is the symptoms which need to be taken care, and what is the prognosis, what is the recurrence period, and how it has to be taken care. And then in between, when you are going to get into a chronic phase, how the lifestyle need to be taken care, how food habits need to be taken care, how follow-up is important, how treatment is important. All this need to be discussed with the patient and their caregivers also is very, very important. And you also need to at times try to look at, because it is going to be chronic. Even if it is an acute phase, there will be plenty of mental health issue which they may be undergoing or they may be facing. So those also need to be tapped by using listening skills, or by putting up plenty of questions of their challenges and their barriers and day-to-day basis practice, all this which we need to put it up, and then we need to find out. Now, trauma and crisis are extremely important area. Trauma can be many things, okay? The trauma can be disease-related pain. The trauma can be rape. The trauma can be domestic violence. The trauma can be road traffic accidents, which leads them to brain injuries or spinal cord injuries. Discrimination, okay? The people with LGBT or people with behavioral disorders, people with behavioral disorder who are under high-risk areas, they also undergo a lot of trauma. And also racism, there is also disaster, there is also poverty, and there is also loss which talks about it. There is also terrorism which talks about it, and there is also trauma related to their lifestyle, what has been happening, how it has been happening, which need to look at it. So all these trauma which leads them to either stress disorder or post-traumatic stress disorder or a panic attacks, or they might land up with a depression. So when you counsel them, there are a few things which you need to definitely keep it in your mind. You need to instill hope, and then you also need to talk about and focus on recovery phases. You also empower them. You also have to focus on their resilience, how it is, and what is the coping skills, how you can strengthen the resilience with them, and the growth. They need to progress with a good wellness, and the healing process also you need to discuss with them and try to make them to understand and try to come out, which takes a lot of time. So when you deal with the trauma and the crisis, you basically need to provide psychological first aid, which has got lot of micro skills which you need to think about it, and especially communication skills, listening skills, observation, appropriate questioning, which is very important, and empathy is utmost important when you're doing a trauma or crisis interventions. Now, when you look at trauma, it has been looked into trauma aware, trauma sensitivity, trauma responsive, and also you have got, okay. So when you look at trauma aware, you need to look at a team who have to be there always. You also need to assess all the facilities and benefits are there the moment the patient is being received, or the patient with the family members when they come, whether the family members' doubts have been adequately addressed. So when you adequately address the condition of the patient where the crisis will not arise, or when they come with a crisis with agitation because their loved one has been disturbed in various other modes, psychologically, physically, and even emotional, they have been disturbed, that need to be addressed so you can avoid the crisis and provide a better situation. So when they come there, you need to define a set goal, and also you need to look at who will be counseling or who will provide the trauma care, and what are the goals which you need to implement based on the hospital rules and regulation and guidelines which has been set for trauma. And you also need to look at it, and sometimes you may also have to repeat over and over again, and you also need to confirm whether the patient and the family members have understood. Now, you also need to be trauma sensitive, okay? So you need to welcome them, and welcome them in the sense not like a different format. The moment they come, you need to immediately take them and attend the patient and maximize the safety. And you also need to make sure your staff in the setting wherever you're working with, they need to be very sensitive enough of not talking or asking or discussing about sensitive issues, or showing extra empathy or sympathy or extra inquisitive to many other issues. then the parent as a resource which we need to have it and focus on the empowerment and the first person language which we need to be very, very clear and strength through the practices which we need to promote. And you need to look at the entire process as a holistic view, and you share the vision across service systems and address staff issues if it comes to avoid the crisis. Now, trauma responsive, if you look at it, recognize and immediately respond to the traumatic stress. What I have said about psychological first aid, which you need to provide, and then start with the stress management. Screen for trauma history, which is extremely important. You also need to strengthen resilience and productive factors, which is extremely important. There is also a need of what kind of an impact the family members are undergoing, family members are through, because the trauma patient we would have received and all the treatment will be going on, where the family members will be waiting outside, or the caregiver or the bystander will be waiting outside. They are not knowing what is happening to their loved ones inside. So that need to be taken care, where the social workers or the medical social worker role is highly important. And we also need to keep it in mind, children, geriatric population, LGBTQ, the counseling process need to be very sensitive, and the skills need to be utilized appropriately when on it is necessary. Okay. There is also another one which we need to look at is children in reducing overwhelming emotion is extremely important. You need to provide an appropriate way. You also need to be trained with that particular counseling skills. Now, you also have to help children make new meaning of their life when there is a trauma which happens to them. Now, if you look at trauma-informed care, you need to look at the entire system on how this trauma has occurred and where it has occurred, and the history need to be taken in a proper manner and systematic manner. Okay, and safety is extremely important, and recovery process which you need to look at it and keep discussing, collaborating with multi people or multi speciality is important, and cross referrals, networking, which we call referrals and networking, is important, and empowerment, strength and resilience, it is extremely important working with trauma. Okay, so for this, you require a special training programs and how to provide a counseling, and you also use the micro skills appropriately, as I have said, which we widely use 5 micro skills. Now, 1 minute. Yeah, the next important thing is breaking bad news. Every social workers working in a major issues or major hospitals who are dealing with acute phase, subacute phase, and chronic phase of diagnosis and chronic phase of illness, which is very important. So what do you mean by breaking bad news? Unfavorable diagnosis, irreversible or untreatable issue, or which you cannot stop, which keeps progressing in life, or the side effects or the complications. Now, surgeries happen. Like one example which I wanted to give you, this COVID pandemic was a very toughest period for all medical people, okay, across the globe. Now, we had a patient who came to a hospital and came with a brain tumor. And the brain tumor was simple. The patient would have been gone home very happily and safely. And when the patient came, patient was tested negative. Patient was taken for surgery. And then when surgery was very successful and patient was transferred to recovery ward, we call it as, before we could send home, we will keep them for an observation. Somewhere patient had some difficulties and patient deteriorated, a lot of fuss and different kind of a issue which has happened. And one fine day, patient was no more. Okay, so when this issue, when this case has been referred to me to break the news to the family members, and I have broken the news to the husband by following, we use spike model. That's what which I have put on the right hand side. I used all the models, and the patient husband had understood, and he had a financial difficulties, which we have helped him how much he can pay, and then we have sent him. And the next difficulty what he had was to transfer transport the patient from Bangalore to his place, which is of around 488 kilometer. And that ambulance which we need to organize, and then we have given him the number and everything we have told, and we have transported the patient. And ambulance driver asked, ma'am, is the body is COVID negative? We said yes, the patient was tested as COVID negative when we took the patient for the surgery, and the patient was fine. So we have sent the ambulance driver, but we have told both husband and the driver to drive safe by following all the COVID protocols. So this happened at 10:30, and the patient was transported. Body was transported along with the husband and the driver. Around 2:45, I got a call stating that, ma'am, the case is positive. That body who's been transported, the test report came because the surgery was successful. Why there was a complication when we tried to test? The complication mainly took place because the COVID positive which has occurred. Okay, we need to be very careful. This is not for threatening or finding fault on any of the team members, because everybody was under risk while treating it. So when the patient was traveling, I have adapted my experience and used all kind of micro skills, what we have learned, studied, and used very well. Sessions I have conducted over a phone, video call it was, over a phone we have done. And another 5 minutes after my session, they both nodded. Husband also nodded, and he was very happy. And driver also said, yes, ma'am, I will take care. Another 10 minutes, I'm getting a call. The ambulance driver did not move, and he stopped the ambulance, stating that I am scared. And he started calling me and said, you put me on mess. And then we have to call him, and then our entire team spoke to the ambulance driver, and he started demanding extra money. So there was sometimes which I felt in my mind, yes, of course, I have discussed with the ambulance driver. If the patient family provides more money, do you think you will not contract COVID? He didn't have an answer. He said, I feel at least justified, he said. Finally, we had a discussion, and we have again, and the husband said, when you've taken for the surgery and the patient was negative, now you are telling me the patient is positive, madam. How is this possible? Then I need to explain to him. So the entire process, 10 o'clock in the morning, it started, ended up at 10:30. And the body was middle of the Bangalore and his destination. Then finally we had discussed, and we also told that the COVID process, we need to inform the health inspector over there, and the body will be shifted over there. And then they shifted and they moved. Everything went successfully with a lot of crisis, and then crisis intervention was given, and so many issues which we had. And afterwards, I was getting a call from family members, and they were agitated, and they said, this is what your hospital does. This is how you function, and things like that which came. And then continuous call. Everybody started calling me, and I felt like, no, I was actually harassed by contacting or providing information. This happens, but yet I did not lose any of my micro skills, especially communication skills and use of silence, and also questioning skills, and also some of the verbal cues which I have used. And finally, the patient family members settled. So breaking bad news is an important skill a counselor or a social worker need to possess at different settings. Now, if you look at micro skills during grief, which I think the same COVID situation, which I have informed, help the bereaved accept the reality of the loss, which we need to definitely give lot of space. Listen, allow them to vent how much ever they want to vent. Help the bereaved identify and experience the feelings, what they have been undergoing. The feeling will be definitely different way of expressions, and many of them will have a defense of expressing themselves, which a social worker need to take care of the defenses what they have been expressing. And you also need to provide sessions and assist living without the deceased, which is very, very important. Somebody is there with me till 10 o'clock and 10:01 that person is not with me, which is not an easy joke for anyone to accept it. So which we need to definitely focus on that. Help find meaning in the loss. It is not immediately you can provide this. Over a period when you're providing a session for them, you need to focus and set priority to the goal. Help finding meaning in the loss, which I have discussed. Facilitate the transition to forming new relationships, like or new interactions in life, or starting their work life and start to learn balancing between loss and progress, which we need to do it. Now, when you look at it, provide time to grieve, which is extremely important. We also need to look at coping. Coping is the major area where we need to look at previously how they have coped. Okay, the use of questioning and the history taking, which is very important while dealing with grief period. Okay, so by this, I would like to conclude my session of social workers working in medical setting, especially dealing with health in a chronic phase. And I also would like to tell palliative care and end of life care is extremely very, very important as a social workers and as a counselor, as a profession. Yeah.
Thank you so much, ma'am. Now the session is open for questions to all the speakers. So you can just type in your questions and we can start it off. So there is one question which has been directed to Dr. Damon Queen. So, one second. So the question is, what is the impact of media on younger people when the news about the suicides are glorified and projected as sacrifice? So I'm assuming it's directed towards ma'am, Damon Queen, ma'am. So,
Damen?
Yeah, ma'am, I'm here. So when you talk about, as I said, the suicidal rates are high in the adolescent age, which is from the late adolescent, probably from 14 to the early youthhood. Media becomes, that is the age where a lot of peer pressures are high. That's where they try to socially, isolate themselves from the family or detach from the family and get into the environmental friends and everything. And why media has got a greater influence, because media sometimes portrays that as a heroic thing. All right, so for instance, as the question posted, sometimes it can be said that is, ending their decision, ending their life could be a very courageous act, or it could be the sacrifice that they are lending it. You can even see that in the concept related to honor crimes. All right, so it's a sacrifice. Killing someone or killing someone for some reason could be a sacrifice. So when that has been glorified, and during the adolescent age, especially, people take this as a, they wanted to identify themselves with something which is very popular. During the adolescent age and early youthhood, they say they wanted to identify themselves with anything which is popular, anything which is trendful, they wanted to do it, anything which is stylish, they wanted to do it. So they, other than that's a stage where it seeks a lot of attention from others. So when this during these ages, when the media also glorify that, glorify that, or portrays that it as a very, very positive way, or as a sign of courage, or it's a symbol of sacrifice, then people also, when they experience something, it's a fragile age, adolescent, so they also imbibe those attitudes from the media. So media has got a greater influence over adolescent and youthhood. Yes, it is.
okay. Thank you, ma'am. Another question that we have got is, can the theory of defense mechanisms of any use in interviews with the counseling clients? So,
So I'm Dr. Nirmala. I'd like to answer this question. Question seems to be quite interesting. There are different defense mechanisms like denial, repression, projection, displacement, and regression, rationalization, sublimation, and reaction formation. All these things, all this defense mechanism will be of use in counseling the patient. It depends upon the situation. I'll give you an example of displacement. So because of the pandemic, many of the software engineers have lost their jobs. This some of their salary has been cut, so they may come home and they cannot throw their anger on their boss or their managers. They may displace their anger on the young kids. The kids may be a bullying. They may bully on their kids. They may be at the receiving end. The kids are the scapegoats. So it is a displacement of anger in the workplace at home. So this is one of the example which you, when you counsel, uh, an engineer or anyone, when he has got problems in the workplace, you can think even about all this kind of anger outbursts at home, where he's trying to vent out what happened in the workplace at home. This is a finest defense mechanism called displacement. Another is, I would like to tell you, is rationalization. you know uh, we had a lot of hue and cry when that person, when we lost a person in the family. He was the most productive person, and he had a lot of talents. He took a lot of responsibilities for the younger ones. When one of the patient's family members may tell us, and we may have to tell him that it is not something unique. You are giving this kind of things may happen to any other family also. Okay. People have lost their family members. Almost all family members are productive. Family bonding is there among the members of the family. So this kind of reaction, we are not finding it so surprising. It is the same in other families too. We should not magnify the situation. We should tell him that it can happen. The similar thing can happen in other families also. I lost a son or a daughter. I lost a teenage son. It's the greatest setback for me. Yeah, for a long time he may be harping on the same thing. If the grief stays for a long time, it may become pathological. So we may have to tell him that the similar situation might have happened in other families also. So you have to overcome the situation. It's a matter of time. Time is a great healer, and you can give him a psychotherapy session. You can provide him a supportive network. You can expand his network, expand his family bonding. You can give other resources for help seeking. So this is one example which I can tell you about rationalization. I told you earlier about the other thing which I told you. Now, denial also. A mentally retarded patient's mother may tell him, no, he was quite all right. His milestones of development was all right. But the only thing is, he could not, the growth period was too lengthy. Like he was not able to talk at the appropriate time, smile, and he could not stand on his own. There was no neck holding and all. There was no babbling at the appropriate age and all. So that means she's trying to suppress, she's going to deny that there has been a delayed milestones of development. So you have to educate her in appropriate way, to explain to the family member, explain to the mother that this kind of thing has happened to the child. There is a stunted growth. The child is retardation has taken place. That is the reason why there has been a delayed milestones of development. Okay. So these are some of the situations where you use your defense mechanism. Depending upon the situation, you can use the defense mechanism. In counseling, in interviewing the patient, yes, in all helping process, you can use the defense mechanism, but use it appropriately, use it with caution, use it with a good understanding. You should have a thorough understanding of the utilities of using that particular defense mechanism. Otherwise, you'll be doing more harm than good. Thank you.
Thank you, ma'am. We have another question. How will you address the issue of those who have lost loved ones due to COVID, in which they cannot even see the body or do last rituals?
Yeah, I will answer this because I remember one of my friends' husband passed away. He was in Canada, I think, Canada, and the family was in India. And it was in the initial period, that was in March, the pandemic started everywhere. And the government has refused to send the body, and they said the burial will be done, the ash will be sent. and the family had a real depression, and the family went on, cried, and then spoke to me and said, why, madam, for us this has happened? Because it was a very close-knit family, and the father was been a father husband, and he fulfilled as a son all his roles he has fulfilled. But he went for a conference, or he went for some business trip. So there he was caught, and he had multiple difficulties, and the flights did not had facilities or clarity of how to commute the dead body or transport the body back. So that was the issue where the government took the initiation. But what the government, beautiful thing they did was everything they have video recorded, because you cannot blame anybody. And that is what I felt it was a good gesture, that they video recorded every process and they sent that to the family members. So situations happens like that. Nothing is on our hands, and few times we will be grieving. But what we need to do is we need to take them up for the longer period of longer period. We need to take them for the session, allow them, because initially when they are grieving, or the moment they have lost, within 1 week of time, when you try to provide a lot of information, try to provide them therapeutic intervention, which will not work. You allow them to talk, you listen to them, you allow them to vent, listen, and then over a period you take it over for all the preparations what I have said to you, the grief period, what need to be done.
Thank you, ma'am. Another question that we have is, can the risk for suicide be inherited? Could you explain? That's the question.
Dominic.
Dr. Damen? Damon?
Yes, ma'am. All right.
Please.
So when we talk about one of the risk factors that are associated with suicide is the earliest symptoms of earliest signs of suicidal ideation, and sometimes if there are any one of the family members are affected, or they already had this ideation, or they have committed, people can draw the signs. Say for instance, that could be the example that they can tell, that can usually happen in the younger age, because they think that that's the only way out, because people who have this ideation, they're looking a way out to end their pain. So probably they could set that as an idea, that this is the way out, because already some person has set that way out. That could be there. But this is what I could generally see from the experiences working in these areas. And again, if there are family members who have suicidal ideation or attempted suicide, it could definitely give an idea for the other persons. But it could be other way also, psychological seeing, because this person has literally witnessed what is the consequences of losing that person. Because as I said in the slide, it is not only going to affect the person who is making the decision to end their life, it could be closely affect the minimum of 6 people around. If they are the 6 people around them, then they know what is the consequences of it, then they may sternly make decision not to do it. So it could be either way around also. And again, when it comes to suicide, it's mostly about the triggers that they have. And when the triggers are so stronger, if they already have an ideation, more higher the triggers, higher the negative impulse, then the decision more stronger towards committing suicide. It's about the environment and the triggers. And naturally speaking, there is always a natural resilience in individuals, because when you are listening, there are too many people who are listening. It is not that we don't have any problems, everybody has it. It's about how are we managing it, what is the resilience, natural resilience we have, how are we able to utilize the coping mechanism that we have, or how are we able to utilize the social support systems that we have. Because a lot of sociological theory says that better the social support, less are the risk for suicide. So these are the other complicated issues that we will look at when working in the areas of suicide.
Thank you, ma'am. The next question is, when it comes to working with clients who have some sort of violent traits, what could be the micro skills that can be useful in this regard?
Yeah, it's a very interesting question. See, my dear friend, violence is a very broad thing which you have told me. Violence to what particular? Is it a men or women? What age? the gender, the age, the kind of situation all matters, because violence, there are different patterns of violence. It may be verbal violence, emotional violence, financial violence, physical violence. So what kind of violence, to what kind of, what gender, what kind of situation, what is the age of the person, all these things should be taken into consideration before we use the micro skills. I think that kind of information requires a very elaborate answer. Please give me more information about what you exactly want by violent clients. What pattern of violent you mean? You can type to us. We'll answer to you, because the answer also has to be elaborate and intervention based.
Correct. To add on, madam, I just would like to add a few things what I have been seeing violent patients in the trauma care center, at least. The violent meaning is entirely different, as madam said. Violence can be because they are not able to pay the bills. Violence can be because the patient, there were few issues which has happened in the hospital. Now and then it keeps happening in the trauma care center. Like for an example, there were two patients who had come. One was a brain injury patient. The other one was a spinal cord injury patient. Now, the doctor had taken a brain injury patient and made the spinal cord injury patient to wait. There was a lot of difficult situations where the doctor has to face, because at around 6 o'clock, emergency and trauma care will be loading with the patient. So the son felt, the mother, the spinal cord injury patient, that patient was female. And the son felt the mother is suffering more, where the doctor has taken the other patient. Okay, but it was not neatly and clearly explained to the or communicated to the spinal cord injury patient. And then there were a lot of difficulties which has happened. They started beating the doctor and started taking videos and various other form of it. And then we need to intervene and then inform them, stating that the priority was given because life and death the trauma patient has been undergoing. For the mother, it takes only a scan and then the medication which need to be provided where she can wait. It is a priority based on the life-saving mode which is being taken. So this is one kind of a violence where you will be dealing with. There is another violence with the domestic violence that, as madam has said, no, we need to really work it out, and mental health related issues, violence which need to be really looked at. And skills, micro skills, it is when it is appropriate which you need to use it. That is what which we have said. There is nothing like a special skills which need to be used at this setting. The other skill need to be used in the other setting. There is no said and done settings. It depends upon the situation where this has to be used. Yes, Lakshmi.
Thank you, ma'am. So we have reached the end of the webinar. So
there is one more question, right? Someone has asked why the social worker role is not being still recognized as important part of the team. And the training, what is that which is needed to improve micro skills? Any team who do not recognize each other. The main reason is, if we do not understand the other person's language, or the other person do not understand what is your role, and you do not have any standard operating procedure about your roles and responsibility, or you're not to be found, or you're not to be competent enough, or you're feeling little relaxed, makes always difficult situation being a team leader. So best thing, if there is a knowledge lacuna, learn from the team itself. If you need a special training, go for a training. Otherwise, don't get worried. It is like Bhagavad Gita, they say one saying, no, don't expect the benefit, keep working, which brings you fame.
Yeah, shall I answer that? Mr. Putumare Gowda, you have been saying that micro skills have to be used in different settings. I do agree. I appreciate your concern, because it's always said that different folks require different strokes. You cannot have a package program, as Dr. Kanmani just now emphasized and re-emphasized also. One one cloth will not fit everyone. So you have to stitch different clothes for different sizes. That's the reason why it depends. You have to understand the situation and use the skill appropriately. Thank you.
Thank you, ma'am. So it has been an enriching session. All the speakers have explained the areas in detail, and it's very evident from the feedbacks that we got in the chat box that they found it very informative. So I would request Dr. Nirmala to give the conclusion remarks.
First and foremost, it's a privilege for me to thank you all for patient listening and asking us questions about the training, about the webinar also. I thank our chairperson, Dr. DHANASEKARA Pandian, who set the ball rolling. He told you about the importance of the micro skill program and the purpose behind it. Why did we have this kind of micro skill program, especially for the student? Because we would like to disseminate the patient-related experiences and the application of micro skills, which is not always theoretical. Okay, in a practice setting, how well it can be used. Then I spoke about micro skill practice in mental health setting. Dr. Damen Queen elaborately spoke on suicide prevention programs. She was very passionate about suicide prevention program. She spoke to you about the suicide, the patterns of suicide, the magnitude of suicide, then the suicide prevention program with case illustration, and she narrated about patients' experiences, how she intervened, how the families cope up with the suicide. All these kind of things. It was very informative. I thank Dr. Damen Queen. I thank Dr. KANMANI TR for giving a very elaborate presentation, very informative presentation on micro skill practice in medical setting. She explained to you about the trauma care setting, patient care, patient education program, where all we can use the micro skill. She even told you about the different setting, gynecology setting, this thing, multiple sclerosis, HIV, and spinal cord injuries, where all in neurology, neurosurgery setting, how the micro skill can be put to proper use. And she also emphasized and re-emphasized that expertise is required in adopting micro skill. It is not a textbook implementation. You should give a thought for it and try to understand the situation before you adopt micro skill. With this, I would like to wind up the webinar. I hope it was very informative, and we would like to have a few more webinars depending upon your feedback, because we would like to disseminate further information, more and more information on micro skill, our experiences about it, and how the patients, caregivers felt about the outcome of the micro skills also. Over to you.
Nothing, ma'am. We can close
Dr.
it.
KANMANI, anything?
Okay.
Anything?
No,
like?
ma'am. No. Huh? Thank you so much. Yeah.
Okay. Thank you, ma'am.
I thank the telemedicine department for associating with the Department of Psychiatric Social Work in conducting the seminar on the application of micro skills in social work practice. Thank you.
Especially Dr. Badamat, who is always a source of inspiration for us. Anytime, every time. Sir, even the last minute when we make it, he makes it beautifully, and he opens the platform for all of us, so that this communication, or what do you call it as, your telemode or online mode, will not get disturbed. And he makes it everything very well. Thank you so much, sir.
Thank you.